everyone, I'm going to tell you how a case of acute pericarditis will present to you on the OSCE stations. My name is Dr. Ashraf and let's begin. The clinical presentation would be a patient who will present with chest pain, which would be sharp. It will be sudden in onset, will radiate to the shoulder. The pain would be pleuritic in nature. So when they take a deep breath or when they cough, the pain will increase. It will also be positional. It will improve when the patient sits up or leans forward, and it will get worse when the patient lies down. It can have dyspnea, malaise, heart racing, plus minus low-grade fever. Most common cause is the viral cause. Also, it can be present after a bacterial infection or a tuberculosis infection. Um, it can also present after a myocardial infarction. Usually, it's after 1 to 7 days. And if it is presenting after 2 to 8 weeks, it's a Dressler syndrome. I've also mentioned the other causes. Please take a moment to read them all. What will be your next steps? So you will perform a physical examination with vitals. You can get an ECG if they are in a clinic, or you can send them to ER for ECG, chest X-ray, echocardiogram, CRP, and troponin levels. You can also get a basic metabolic profile as well as a complete blood count. On physical examination, you will do a complete cardiovascular examination if you have time, do lung auscultations, also do pulses and Brui. Or in complete CVS examination, you also do a JVP exam. What is the specific finding? You're looking for a pericardial friction rub. Make sure that the patient is leaning forward and the friction rub is heard on the left sternal border. The ECG findings will be diffuse ST segment elevations plus minus PR segment depressions. They could also just present with tachycardia, but for exam purposes, this is important. So you're seeing a diffuse ST elevation and the various leads, lead 2, lead 3, so AVL. So in almost all the leads, we have ST segment elevation. Your differentials could be a myocardial infarction, myocarditis, or Takotsubo syndrome. The treatment is to send them to the ER for further investigation and rule out other differentials, treat the underlying disease, give them high-dose NSAIDs or aspirin. Ketorolac can be used, but if the patient is in severe pain or if they cannot take anything orally. Colchicine for next 3 months. If the patient has TB pericarditis, send them to the TB clinic. Also ask them to restrict physical activities until the symptom resolve. So strenuous physical activities. And then you can refer them to cardiologists as well. Complications can be recurrent episodes of pericarditis. They can have atrial arrhythmia, pericardial effusion. These are all the complications that can present after pericarditis. Prognosis is usually good if the patient is presenting with idiopathic or viral pericarditis. They can have a poor prognosis if they have the onset is subacute, if they have a high-grade fever, or they have a 20 mm pericardial effusion on echo, and if there is a lack of response after 1 week of therapy. So thank you so much. I hope you benefit from this video. If you have any questions, please comment. And don't forget to subscribe my channel. Thank you.